We're on episode 161. I'm Amy Cohen. I'm a clinical psychologist, and I am the director of SMI Advisor, which sits at the American Psychiatric Association. And I'm thrilled today that we're also going to have Jenna Mehnert Baker with us to talk about transforming crisis, about state and county partnerships, which a lot of our states are struggling with. How does the state do things, and how do we get that down to the counties, and how do we interact together to make the best care that we can? Few reminders as we get started here. Remember, you can always go to the Crisis Jam learning community on the web, look for old episodes, see who's coming up, and also request your unique link. Great presentations last week about Franklin County. Loved that. We talked a little bit about Elmo and how his new campaign had really garnered a lot of feedback. So it was a great week last week, but today is going to be fabulous just as well. All right. Can you believe it? We've had over 400 unique speakers. It's incredible. Here are just some of their names of all the people that we've had. And if you have an idea of a speaker, and I kind of said this before the top of the hour, but some of you weren't on just yet, which is absolutely understandable. You've got an idea for something, send it in. We'd love to hear from you. If you've got a great speaker, or you've got a topic idea, or you have both, the speaker and the topic, send it in. We'd love to hear from you. All right, a little bit of news, as we always start every week with a little bit of news. So this was an article about 988 suicide hotline calls in New York being routed out of state. And there was some legislation put forward that requires the FCC to establish multi-stakeholder advisory committees to really help us understand about geolocation, right? We know this is a worry of the audience, right? So how do we do it so that people feel like safe when they call in, and also that their local 988 is actually answering the call, can help them with local supports. For the most part, 988 is getting mostly good reviews, and I hope where you live, you're hearing good things. Of course, there are still questions about suicide routing, call routing, which we just talked about, and also adequate staffing for the number, the immense increase in calls that we're getting. I know that at the SAMHSA website, there's even a place where you can refer people to look for jobs on 988 crisis call centers. So there's jobs that are out there. We need to build up our staffing so that we can get a really strong behavioral health response for those people who are in crisis or just in a mental health moment where they need someone to talk to. So here's a task for you. When you're out over the next few days, next couple weeks, look around, see if you see something about 988 somewhere. Here is an ID badge that somebody sent in. This was an Arizona college student. Back of his badge showed 988. If you see something, I think there were going to be some signs in parks. Maybe you're seeing, the other day I saw somebody with a 988 shirt on. Take a little picture and send it in, because we'd love to include these in a kind of 988 spotted segment. So let us know. All right, just a quickie note, the Crisis Now third annual summit registration is open. All right, the hot seat. As you may have heard from me in the past, that's the one thing I never want to do, is the hot seat. But I love to participate in the hot seat as an audience member. So today we are the hot seat. All of us together are the hot seat. So let me bring up the question, get ready to answer in the poll. Don't call it a hotline. Adrian Bridenstine, VP of Policy and Communications at Behavioral Health System Baltimore, led a 250,000 market research and community engagement project to figure out, how do we best talk about 988? So in doing this, one of the things she came up with was a new tagline that Central Maryland is using on their 988 website. Okay, Maryland folks, if you're on this call, you better get it right. But we're going to all help. Is the new tagline anyone, any struggle, anytime? Is it hope, help, healing? Is it trained counselors 24/7? Or is it we're here to help? Enter your response now Push submit. Once we get a nice group of you responding, I'm going to see what you had to say. The new tagline. Ooh, we've got a split audience. Nobody liked trained counselors 24/7. They probably thought that's it. Everybody does that, nothing special. Looks like a lot of you, half of you thought it was anyone, any struggle, anytime. I like that one too. And then there's a split between home, help, hope, help, and healing, and we're here to help. So, who was correct? We're here to help. 25% of you said we're here to help. Notice how we're starting to use plain language, not a lot of these specific, helpline crisis. More of this, we're here to help. We're here to help anyone with any issue. And Amy Brinkley got it right. I love it, Amy. All right. Good job, hot seaters.
We serve people who just want to talk sometimes.
Aha. Very similar to what we just said about using plain language. You see, there's nothing in there about hotlines. There's nothing there about mental health. There's nothing there about crisis. Real simple. We help. We just are here for people who need or want to talk. I love it. Along these same lines, 911 calls are rerouted to local call centers. There's no reason we can't do the same for 988. We know the 988 Lifeline is a proven life-saving tool and should maximize its full potential. Again, looking for input to make sure that geolocation and routing makes sense for our users and for our call centers. All right, it's my absolute pleasure to introduce Dr. Jenna Mehnert Baker, and then some of her colleagues and from Pennsylvania talk to us a little bit today about state and county partnerships. Thanks, Jenna, for joining us.
Oh, I'm grateful to be here, and I appreciate the opportunity to talk about, modernizing the crisis system. If we can think about the Commonwealth of Pennsylvania as truly a Commonwealth, we can see the significant challenges. This great picture is from Philadelphia, but if you've been to Pennsylvania, you know that Pennsylvania and Pittsburgh are over 6 hours apart. So it's a very large, diverse state. So if we could go to the first slide, please. So as we think about it, right, I mean, we here in Pennsylvania, as the 5th most populous state, license our crisis system through 1993 unpromulgated regulations. And I should start by saying that I am the policy director for the Office of Mental Health and Substance Abuse Services within the Pennsylvania Department of Human Services. And I am also on the board of directors for CIT International. I just have so much passion for this work. I would just jump right in.
But I was going to see, not use this, but like something this size.
So, as we think about Pennsylvania, and we all agree, I think, across the nation of the importance from the Stepping Up Summit to decrease folks with mental illness being brought to jails, when in fact, we know they'll serve 4 times longer for a misdemeanor level offense. And also the level of boarding that's happening in our nation's emergency departments. They were not built to be urgent mental health care facilities, but often with nowhere else to go, that's where folks turn. So we do definitely in Pennsylvania have those 2 challenges in place. And we also definitely want to create immediate access to crisis supports, which we have in some counties and not in others. And of course, the critical importance that we all believe in that the crisis system will help us do is to eliminate, the criminalization of symptoms by giving law enforcement immediate access to other options other than jails or them having to, wait in emergency departments. So in Pennsylvania, just like the rest of the nation, we're very excited about SAMHSA's toolkit, SAMHSA's roadmap, and this work that's happening. And we've been talking to everybody we possibly can to gather wisdom from other states and really then work in partnership within the Commonwealth. Next slide, please. So we are truly, people say they're a Commonwealth, but we truly operate as a Commonwealth. So we have 67 counties, and in those 67 counties, there are county commissioners that govern what happens in that county. And we actually have 48 different mental health systems in the sense that they are got run by their mental health administrator, several mental health administrators. In fact, the two you'll hear from today, Annie is the administrator for 2 counties and Tina is the administrator for 3 counties. So we call those joinders when counties have come together to operate their mental health system. But still, there's 48 different professionals with different levels of knowledge and experience who are in these roles. And our responsibility as the state, so the office that I work for and the bureau that I am the director of, we write the regulations and issue waivers for providers. We also oversee all the community mental health services block grant dollars that go out to counties. And just to complicate it a little bit more in the Commonwealth, in a positive way, we are a behavioral health carve-out state, which means my office also manages the Medicaid policy and writes the state plan amendments for the spending of MA dollars within our behavioral health system. And we do have a separate Department of Drug and Alcohol, which manages all of the opiate settlement money and licenses the specific DNA services. But they are not the Medicaid authority, the Department of Human Services is. So, we fund crisis services and have for a very long time under our rehab option of our state plan. And, as there's the mobile crisis option where you were required to have licensed folks on the mobile crisis team, we had a CMS grant, it did an assessment, and we really don't have very many licensed people working in mobile crisis. We also, outside of Philadelphia and Pittsburgh and some of our more suburban counties, don't have 2 people on our mobile crisis teams. We have one person teams that are not really operating 24/7. We have a very large population. And as I mentioned, being a carve-out state, in addition to our county partners, our behavioral health managed care organizations with our providers are our partners. So we've got county leadership, behavioral health organization leadership, primary contractors that work directly with the BIMCOs, and then our providers. So I keep talking about crisis as a big boat. We all got to get in to make positive change happen. Next slide. So here we have, in Pennsylvania, they were required to have their own call centers based on our Mental Health Procedures Act, which was passed in the 70s. We recently issued a bulletin saying they don't have to have that. They can utilize 988. Many counties have retained their own county crisis lines, but we are at a 988 answer rate of 89%, and we are working to ensure that our crisis centers do mobile deployment. We've recently looked at our 302 process. It's different than other states. And it's interesting for me, having worked in Maine, New York City, and in Washington, D.C., how different states are. We have a 120-hour hold when the national average is 72 hours. So it's just a lot of, as we all know, our states are all very different in that nuances. And we are working to revise and issue new regulations from those 1993 ones that really reflect SAMHSA's best practice around, mobile crisis response. I saw Paul post, so he'll be proud to know that Paul from RI, I only say emergency behavioral health crisis walk-in centers, even though it takes a long time, because we're very committed to parity with private insurance for those centers. And short-term crisis stabilization, both more of a medical model, and big fan of People USA. We strongly support peer-run crisis programs as well. We have distributed $41 million of ARPA money to start this modernization and support counties and their work to do that, in addition to obviously the federal $988 that all counties are receiving. Next slide, please. So we really are working to do the collaboration that some folks already have in place. When you think about 12 different call centers, all of these 48 different systems, because the counties select their mobile crisis providers and they usually stay within their county parameters. We have challenges around expanding access to 2-people teams that respond 24/7. We're really very focused. It has not been something that existed in the past. We are very focused on embedding certified peer specialists and certified recovery specialists into our mobile crisis teams. We recently had our state plan amendment approved by CMS, to change eligibility for peer support. Historically, we only allowed folks to be peers who had identified as having an SMI. We now, our language is lived experience with a mental health diagnosis. So we're really trying to have lots of conversations with mobile crisis providers about the importance of having peers on their crisis teams. But it has not been common practice in the Commonwealth. And also making sure that mobile teams understand that it should be working in partnership with law enforcement, creating emergency behavioral health crisis walk-in centers, because outside of Philadelphia, we really don't have the medical model where somebody can walk in and have immediate access to an advanced practice professional or a psychiatrist and be diagnosed and have medication administered in that true 23-hour window, and the kind of the models I think we all know that Connections and RI International provide across different states. And our regs are also going to create peer-run crisis stabilization programs for the first time, which haven't been licensable on their own previously. Next slide. And I want to talk for a second about the importance, that I say the 3 Ps when it comes to crisis, because I really talk about a big boat and we all have to work together, whether that's law enforcement, our mental health administrators, our providers, our BIMCOs, those core partners, but then everything else, the area agencies on aging, obviously our single county authorities, because this is not, we cannot let it be a mental health system and then an SUD system. It is a behavioral health crisis system. So we're really trying to, ensure that all of these different voices feel respected and heard and are part of this system evolution. So I really think, the importance of partnership, that we're all in this together across the Commonwealth, the problem solving, being able to listen to the different perspectives, what are the concerns of our single county authorities on the drug and alcohol side, our mental health administrators, what are the law enforcement concerns? How do we get folks to really fundamentally in the Commonwealth change practice from, thinking that someone, before someone's involuntarily committed, we should actually see them, because that's not a requirement in our law. How do we really think about expanding access in a way that destigmatizes seeking help, while also being able to fund that for counties? And so the listening and the open communication is critical. And then the perseverance, because, when you're dealing with 48 different administrators and all of these different counties, there's folks who don't believe right now that we can do this, that we can implement the SAMHSA toolkit in such a large, very diverse, right? We have urban areas, lots of suburban areas, and super rural areas in a very large, very populated state. So really the partnership, the problem solving, and the perseverance are critical. And some of the things we've done, as I said, we did the eligibility for certified peer support. We are also in the process of creating certified peer support for certified family peer support. Our regulations will allow any peer-based certified individual to automatically be a crisis intervention worker. We also had a NASH bid award to create an online crisis intervention worker certification. That was so that we could make sure that providers got folks trained quickly. If they needed 1 hour of training, they didn't have, and they had 1 employee, they didn't have to, do that one by one. And also, crisis endorsement training. It's a 3-day training for peer professionals who are already certified to work in crisis. And we've funded our local NAMIs, about 28 affiliates, to make sure they're doing family to family, peer to peer, and NAMI basics, and participating on their CIT steering committee, because CIT is not a law enforcement training. CIT is a community program, and you're not doing CIT if you don't have a steering committee that includes mental health professionals and advocates. You're just doing a training and calling it CIT. So we're really also, as the state, have invested in building up our NAMIs to make sure they're core partners in all of the crisis work in partnership with their counties. And we have 500 certified peer specialists inside of the Department of Corrections. Not all of them will be released, but we also had a NASH bid award to work on creating some solid bridge programs to get folks who are CPSs, who are appropriate to work in crisis, into our crisis system as they re-enter society. So that is, kind of some of what we're doing around workforce. But next slide. This is my not pretty map. I am not a graphic designer. I am a social worker and a public administrator, but I have found the value in having a graphic as I go around for all of the audiences, because clearly I will speak to anywhere, anyone, anytime, and trying to help them understand or visualize. But I want to stress again that I can do all of this work. I can talk to all these people, but without my partners and friends in the county, and without us working together in this, it's not possible. And even if you're not a county administered system, I think if your crisis approach doesn't include a really big boat and you don't ask lots of people. I mean, when I say, I reach out to Paul, I reach out to folks to say, so what do your crisis regs say about this? Because I don't want to just make something up in Pennsylvania. I want to know what's worked in another state or failed. So the more communication and collaboration you can engage in, and the more you talk to I spend time talking to the direct practice mobile crisis workers, and I spend time talking to families and individuals in crisis. Because if we don't work collaboratively with this kind of systemic transformation, we won't meet the goals we all want, which we know our suicide rate keeps increasing and the age of people dying by suicide continues to decrease. We have to work collaboratively. So with that, I want to make sure that I call out my two partners in all of this work, two of my many partners, but two I talk to on a very regular basis, to have them add their wisdom and perspective.
Welcome, Annie and Tina, representing together 5 counties of this great state we just learned about. So let me hand it over to the two of you to have some remarks on what was just presented.
Well, first, thank you for the invitation to join you folks. I definitely agree with Jenna's analogy with the big boat. It really does take a whole community working together. It takes all of our state administrative staff, as well as then all of our county partners, to work collaboratively. And when I say the county partnerships, that's not just mental health. That is truly, literally every facet of our community. It engages our 911 staff, our law enforcement staff, our emergency management staff, EMS, as well as our emergency rooms. We've been really trying to strengthen literally across the whole spectrum, every stakeholder's engagement in this. So for us, specifically, we've been really excited about the opportunity to expand, to create a system transformation where we can align with SAMHSA's best practice guidelines for crisis intervention. For us specifically, we're working on a regional emergency behavioral health crisis walk-in center with Dauphin County, Cumberland County, and Perry County. So literally it will be serving 3 counties, and there will obviously be other people who join us as well, other guests who come to the service. But we're excited about this opportunity, and we're early in the process of development. We've been convening weekly meetings with Connections, who's our provider, and we're hoping to have the program be operational by the end of this calendar year. So we know this is a huge lift, and we're just excited about the partnership with the state, as well as their support, because really this is about serving our communities with excellence. And ultimately, we believe there will be positive outcomes literally across other parts of the system. We believe 911 calls for people experiencing behavioral health crisis will decrease. We believe the number of individuals who are incarcerated as a function of their mental illness will decrease, and that will help us with our stepping up goals as well. So there's so many positive outcomes associated with this crisis transformation that it made it pretty easy to jump on Jenna's big boat, to join with this, and then to work hard to try to make it a reality. Of course, as part of this as well, from the sustainable funding piece, that's also going to be something that we're going to be working in collaboration with OMSAS and the Department of Human Services, as well as our Medicaid partners. We really want to also ensure viability because of parity, and making sure that private insurers will also be paying for the service. So we know there's a lot of work ahead, and but there's a lot of great energy. As somebody who participates in the Crisis Jam as often as I can, you guys keep us going because there's so much positive energy here, and we really appreciate that. Tina, go ahead.
Thanks, Annie. And I echo most of what Annie all of what Annie talked about. I think that in our 3 counties, again, 2 extremely rural counties and one that's trying to be a little bit more urban, but isn't really succeeding quite yet. But so we have quite a continuum of services that we're pretty proud of in our counties. We do have telephone crisis. We have mobile crisis. We have medical mobile. And we have in one county, in a Carbon County, which is one of our rural counties, we have an emergency behavioral health walk-in center that's been operating, I think, for a year and a half at this point. And as Annie said, while it's primarily Carbon County, we've gotten people from all of the surrounding counties who are using that service. And about 60% of the people that use that center do not have Medicaid. So again, that parity is such an important piece. If we can get private insurances to pick up their fair share of the costs of those, we would be in a much better place with sustainability. I think that one of the things, or a couple of the things that are challenges for following the continuum and the roadmap is that staffing, huge issue, especially in rural counties. Well, probably everywhere, but our rural counties, the distance that people have to travel to work, if they are mobile, if they have to go out, it can be an hour or more from one end of a county to another. And if you go through our 3 counties, you got 2.5, 3 hours that you're talking. So we need, people to be able to drive if they're working. And then for the behavioral health emergency walk-ins, for people to get there sometimes is a little bit difficult. So those are 2 things that we're really trying to focus on how we can make that better. And then another thing that I'll say is that we are working very closely with all of the partners that Annie mentioned. I think it's crucial too to bring in the legislators and commissioners, all the local folks who are elected and have some push and pull in the political realm, because they don't always understand what all of these things are and how it ties into your regular community member who doesn't have mental health issues, but it affects the entire community when people are not healthy. So the healthy community is kind of where we go when presenting to those folks. And we really want them to get the idea of how the whole community can't be healthy if all of the community members don't have their needs met. And then that brings me to my final thought, which is building this crisis system is fantastic. I'm very excited about it, a little bit scared if I'm being honest, because it is a lot of work. But we also need to make sure that we're building the infrastructure of the mental health system, because it's great that we can help people when they're in crisis, but we need to keep them healthy so that our crisis system isn't overburdened. So I think that that's an important piece too. We need that infrastructure. And we're currently working on our second emergency behavioral health walk-in center in Pike County. Well, it'll actually be in Wayne County. It's a collaboration with Wayne and Pike, both extremely rural counties. And so we're in the process of building that now. So that's pretty exciting because they have very few services in those counties. So
it's been so wonderful to hear people with lived experience, as well as our local NAMI affiliates. They're also very engaged in the conversation. They have been supportive and participating with review of proposals and literally every facet of the development of the project. We've done our best to make sure we have literally all stakeholder involvement, because ultimately that's how we're going to get the best service to serve our community. And so this has been an exciting time. Mirroring what Tina said, it's been exceptionally busy, and we're excited about the future, though. We just have to keep things moving forward.
Mm-hmm. When I hear you, Annie and Tina, speaking, and we didn't know each other before today, I'm just struck, and I know there are other people on this call like this, about what incredible advocates you are for your community. That's what I hear And when you have a partnership where you have incredible advocates who are in the weeds in their community, and then you have a leader like Jenna who's listening, who says, I want to hear from you. Well, tell me how we can, break down these silos and connect people and make care feel like care. The end point is going to be good no matter what. But I think a lot of us on this call also resonate with the fear, with the how much we have ahead of us. But we're at a moment in our mental health growth that is just kind of incredible. It's incredible the attention it's getting. People are feeling more comfortable talking about it. People are feeling more comfortable asking, this is what I need. How can I get that? And to have leaders like the three of you in the great state of Pennsylvania, Commonwealth, is just really heartening to the rest of us. And I really appreciate you speaking today. And I'll give Jenna the last word if there's anything she wanted to add.
No, I just want to add how important it is to have these conversations with folks at all levels of government and with your lived experience perspectives, whether that's your NAMI or your statewide consumer organization, because they're obviously part of this work with us as well, because it is such a transformation and so important that we really do all need to work in partnership, because it can't be successful if people are doing it separately and not together. And once again, that does include law enforcement, and it does include the wonderful CIT model, where we really is a program, not a training. I just have to say that again. So I will put my email in the chat if there's anybody who'd like to have further conversations, but I just want to thank everyone who's watching the Jam today, because I know that means that we're all in this boat together, and that's how we'll make a difference nationwide. So thank you all for your time.
Thank you so much.
Thank you.
All right, so we're going to move on to the SAMHSA update. Is Dr. Belina Shaw on?
I am on, and I have had technical difficulties, and my internet's gone out twice in the last 2 minutes, but it was working for the whole rest of the jam. So we'll hope it stays. Hi everyone, Belina Shaw from the Center for Mental Health Services. I'm here to do our monthly update. I know that often the 988 office is here, and I know some other folks are on as well. I just as far as updates go, I was able to join the 988 office on a broad visit to Arizona. We were able to visit over 3 crisis centers, mobile crisis teams, also call centers, really all the 3 pillars. And the most important part of this was being able to see the actual system at play, right? We just heard from Pennsylvania talking about a statewide system and just how important that is. And, and as I reflect on that, I was also able to do some a law enforcement ride along as well. And really, and also the payers were involved, right? I could just go on with a list of the multiple people and state entities and local entities that were engaged there. But what was most important to me was just that system and community that was formed. And I think one of my major takeaways is that, everyone has to be in it together, and you have to have that shared, shared responsibility and accountability as a community, but also having one major entity that is really making sure that they're going to be the driving force and having that overarching accountability, so that really all the pieces can be pulled together. But as that system is developed, it's really important to have all voices at the table in the beginning, middle, and end, and ongoing iterative elements of these processes. And as far as all of those voices can also be heard at all levels of government, providers, people with lived experience, state, local, federal government. So I'm also here today at the National Association of County Behavioral Health Disabilities Legislative Conference. And it's a great meeting where actually I was really inspired this morning by a panel of young professionals. We talked about workforce. Actually, this would be a great panel for this. I'm just thinking aloud in the future, but just about young professionals in the behavioral health field, and between bachelor's and doctoral level, and really what has inspired them to be in and stay in this field. And then there'll be a couple of panels of through your traditional partners of, your CMS and SAMHSAs of the world, of traditional partners, federal partners, but then also non-traditional partners, such as USDA, for example. I think USDA, especially when you're thinking about rural communities, is an often underutilized resource, especially in the health space. So, I think that I'm excited. We'll have a panel tomorrow on 988, and John and I will be presenting, and then there'll be a little bit more of that as well. I think that we're really looking forward to presenting tomorrow afternoon, and then also continuing the system building at the local and community and state levels. So I know the 988 office is preparing for a policy academy in April, and they are going to be finalizing their state teams and alerting the state teams imminently. And also we're also in the Center for Mental Health Services going to be doing a policy academy focused on local communities as well. And one of the things that we learned from that broad visit around Arizona is that each local community did things a little bit differently to meet the needs of the people that they served. So there'll be a state policy academy and then a local policy academy, and that one will be focused on rural communities, knowing that actually just what was said today, that each community, especially in the rural communities, that sometimes these guidelines can be a little bit more challenging to implement. So just stay tuned. As far as the policy academies, you'll hear more details about them, and the technical assistance that we're providing at SAMHSA. So that's it.
Dr. Shaw, thank you so much. I mean, I think, so many of us have benefited from your wisdom and the wisdom of SAMHSA as we've begun to try to meet some of our goals on the crisis care continuum over the last year and moving forward into the next few years. And I think I speak for many of us on this call. I've heard people talk about this, how much it has meant to different communities that SAMHSA has been out in the field and visiting. And it's just really meant a lot to people that SAMHSA values these visits, listening to people on the ground who are trying to overcome different things, and that you really take it, digest it, and help us move forward. And we really appreciate that from SAMHSA. So thanks for joining us today. And I'm glad your internet didn't go out while you were talking.
Thanks for all of the people that have visited and their input, because we do value it, and we use it in the next generation of the work.
Wonderful. All right, so let's turn to Nashville. Brooke Doyle, are you here? Brooke? There
Yes.
you are.
Hi, good afternoon.
Do you want to introduce yourself?
Thank you. Yes. Hi, everyone. I'm Brooke Doyle, Commissioner with the Massachusetts Department of Mental Health. And I was invited here today on behalf of Nashville to present some information about an innovative youth service that we've recently started. Oh, good. I was going to say, I'm not sure how to get the slides up. Thank you. Massachusetts just began implementing a youth PACT service. PACT is Program for Assertive Community Treatment. And we are one of 2 states. New York also has a youth program for assertive community treatment. So for Massachusetts, the program is procured through DMH's Child, Youth, and Family Division. There are 7 contracts, and we call it PACT-Y. It's a comprehensive service for individuals under the age of 22 with serious emotional disturbance for whom traditional office and community-based interventions have not been helpful. It's a multidisciplinary team, including a program director, prescriber, clinicians, outreach workers, family partner, peer mentor, occupational therapy, registered nurse, EdInvoke specialist, and a program assistant. Each contract has 20 enrollment slots. Next slide, please. This is just a quick timeline to show you just how new these really are. We began enrollments literally just a little over a year ago. So some of the material that I'll show you with the early results really are reflective of very early enrollment. And we expect to have more information as the teams mature. And if you could move the slide, please. Thank you. As I mentioned, the teams are not yet at full enrollment. We have 71 youth enrolled. This is as of since February of 2023. And this gives you a little sense of the racial ethnic breakdowns, the age groups of people we serve, and the gender breakdown of people we serve. As you can see, a large proportion of enrollment are for youth between the ages of 15 to 18. We also do receive younger youth in the 10 to 14 age group, and youth who we would consider more of that transitional age in 19 to 21 age groups. Next slide, please. This is just a little sample of where the enrollment is growing. So as you can see, it's picking up all across the state. These teams are positioned in communities that serve a geographic region. So they can take referrals across all these regions. DMH, as our state agency, is divided into 5 regions. Each region has at least 1 team, and Western Mass has 2. Next slide, please. So this gives you a little flavor of what we're seeing. Again, these are very early results. The early results are positive. We use community tenure, meaning the ability of the youth to remain out of institutional settings, as the measure for positive community tenure. And here you'll see that 85% of youth remain in the community. And so that means the youth enrolled did not have a psychiatric hospitalization or what is considered a subacute level for us, the CBAT level, which is community-based acute treatment during the measurement months. We expect that we will see some movement in this number as the enrollment picks up. And so you'll see some of the dipping reflects also just changes of enrollment rates. So as the enrollment stabilizes, we expect we'll see a more clear trend line around this, but we wanted to be able to give you an early sense of what we're seeing. Next slide, please. We wanted also to be able to show you just in this first year, what are we seeing? The numbers are not, the actual numbers of those discharged are not included because the numbers discharged are below what the HIPAA privacy law allows us to publicly share. So that is also a positive sign that people are enrolling and staying enrolled. And of the youth who were discharged, 50% were discharged into a community-based service that was less intensive, and 50% required a higher level of care. Again, these are low numbers. So we just want to acknowledge that there's more to learn as the service progresses and matures. And these were just some early indicators. Next slide, please. So we wanted to give you just one anecdotal experience of a mom of a youth who's receiving the PACT-Y service. She was blown away, and she's been asking for a service like this for years and had been so positive. They feel really supported, especially for the occupational therapy that's provided as part of the integrated team. And not on the slides, but just for awareness for people who may be wondering, the service right now is supported with state funding. And at a point when the services are more mature, We anticipate that we will be working with our Medicaid providers to include this service as an option. That will come a bit further down the road. We wanted to use the state funding to support the teams as they were standing up and maturing. And here in Massachusetts, we do have a law that requires rate regulation for services, direct care services. And the regulated rate is $207 per enrollment day. And that's for the full team support. Thank you very much. Appreciate the opportunity to join you here today, and welcome an opportunity to come back at another time, maybe after the teams have matured a little bit, so we can share out exactly how things have progressed.
Thank you so much, Commissioner Doyle. I just want to say, you know, Massachusetts has been a leader in so many ways, and we really appreciate that you're sharing with us this slice of the work you're doing for youth. A lot of people on this call are really interested in how to tailor services for youth. One of our most popular sessions is one where we had youth on who told us really what they want. And we've had people who are on crisis lines led specifically by youth. So this is definitely an interest of this group, and we appreciate that you shared this with us today. And I actually really looking forward to hearing what happens in 6 months to 9 months with these groups. So thank you for joining us today.
Thank you very much.
We'll move on to our state updates. Is Caitlin Davidson from Vibrant here, or Catherine Gilly from NAMI?
Hi, it's Catherine with NAMI. I think Caitlin is unable to join today.
No problem. I know you can carry it.
But thank you. We have just a few updates today. And a couple changes to the map. So Vermont has a fee bill, H657, that would fund 988 call centers, among other things. It already had one hearing, and it'll be heard again in House Ways and Means today at 1:15 p.m. Eastern, so just in a few minutes, with a potential committee vote tomorrow at 9 a.m. Eastern. And Maryland has companion fee bills, HB 933 and SB 974, which would establish a 25-cent 988 fee. And they are both scheduled to be heard in committee on February 28th. And then just last thing for today, great news, New Mexico has received approval for the federal enhanced 85% Medicaid match for mobile crisis teams. So states are still able to apply for that, go through 2027, I believe.
Great, thanks for the update. We will move to our crisis talk guest, Lizelle York. I hope you're here. Lizelle?
I am.
Oh, wonderful. Hello, welcome.
All right, thank you so much.
So I understand you're the Director of Communications for Behavioral Health System in Baltimore, and Stephanie Hepburn had a chance to talk with you. So I was able to listen to a little bit of your interview, and I was wondering if we could you really use data to gather information on what people thought of your Here to Help hotline. Correct. And I'm wondering whether, I think you use that data to really help people understand how to use the service and what would make them want to use the service. So can you share with us a little bit about what you learned from that data?
Sure. So let me take a step back first. So
Okay,
the Here to Help hotline was a service that was provided in Baltimore City, and that was something that was administered by or supported by Behavioral Health System Baltimore. Okay. So our approach to 988 has been regional. So the outreach that we're doing is not just for Baltimore City; it also includes Howard, Baltimore, and Carroll County. So we knew, because we were moving from marketing for one service in one city to marketing for a regional approach, that we needed to be guided by data, talking to people, hearing from them how they felt about the service that is coming, because if we don't get them ready for it, they're not going to use it. And so we hired a market research team in the summer of 2021 to get us ready for the national launch of the 988 helpline. And so what we learned from the research, which was conducted through surveys as well as focus groups and informational interviews with residents, as well as, key informants across the region, was that word helpline was a very important change that we needed to make in our approach. Hotline just did not resonate well with people, and in their responses to us, they said they would be more likely to reach out if we use the word helpline to sort of lower the barrier for them to engage. We also found that talking about emotional support was better language that people were more ready to resonate with, and that helped them to reach out as well. We also found that talking about, surprisingly enough, saying, trained counselors did not give the meaning that we expected. They sort of felt that, you just trained for a short period of time and perhaps weren't as experienced as the word would denote. And so we started to talk about specialized counselors. So we made some language changes. We also realized that we needed to have some local connection. So you will see that the colors that we use are very different from the blue that you would see with SAMHSA. And these colors actually came from the Here to Help helpline. And this is Baltimore Ravens country, which is purple. And so we felt, in the testing that we did with the look and feel of what the brand should look like, it was something that resonated a lot with people. So we tried to make that local connection using everyday language that people could respond to as a way to help prepare people, to accept 988.
Lizelle, thank you for your insights today and thinking about how to make something personal and to reach out to individuals and have it resonate with them. I appreciate you joining us today. Thank you.
Thanks so much.
All right, we're going to move on to our lived lens, one of my favorite parts of the Crisis Jam. And today I'm lucky to introduce Rachel Havocost, who I had the pleasure of meeting in person just a few, I don't know, maybe 10 days ago. And so I want to hand it over to you, Rachel. This part of the jam is the part where we really try to focus on what are we reaching for? How do we make care feel like care? And I'd love to hear your insights on that.
Yeah, absolutely. I know we're kind of running short on time, so I'll try to be quick.
Yeah, take a breath. We got it.
Okay. So first of all, I'm so happy to be here and very grateful that this exists. Already, this is something that feels like care. And as someone who I've been in and out of mental health services for the last 19 years, individual therapy, group therapy, intensive outpatient, I've been hospitalized, peer support groups. So I've kind of experienced the gamut of mental health care. And I think like an overarching theme for me is the dehumanization of being in care. And so I think about this concept of like how, care feels like, how can we approach it so that we're treated like a human to help and not a problem to solve? And this goes for the entire continuum. And it's not just about when we're in crisis care, it's before we're in crisis. Is there enough reduction of stigma and shame that I feel safe to ask for help or talk to my friends about what I'm going through? Do they have the language and verbiage to say, hey, it seems like you're struggling with this. Why don't we try calling this number or reaching out to someone, right? So have we desocialized the stigma around mental health that I feel like the care is available to me before I'm in trouble? And then obviously when we're in crisis and I go somewhere to get stabilization or to get support, while I'm there, do I feel like I'm being treated like a human? Do I feel like I'm actually being provided the care that I need personally? Because not everyone is going to be the same. Is it inclusive? Is it trauma informed? And then when I leave, am I being given options for what to do after I leave, after I've been given the support I need? Am I given a recommendation for a therapist or for someone to talk to? And when I go back into my society and my community or my workplace or school, do those systems have the language to say, we recognize that you've just been through this thing and we're here to provide you with the care that you need? And so it's a sort of like holistic loop that I think of, where it's not just about when I'm in crisis that care needs to be there. It's during the entire time. And because when I was hospitalized for a suicide attempt about 8 years ago in New York City, and I felt like I was just put into a place where I was basically waiting for them to say it's okay for you to leave. And once it was okay for me to leave, there was no recommendation of what to do after I left. When I went back to school, I was cleared for classes after a 30-minute session with a therapist. And then there was no discussion with my family or friends or anyone about how I was doing. And so it really felt like I was a problem to solve, rather than a human that needed help. And so that's what I think about when I think about what it feels like for care to feel like care. It's when it's the whole entire spectrum and not just when I'm struggling.
Rachel, I knew there was something special about you when I met you 10 days ago, and I'm just reminded of that today. And so I think in general, like, we just need to approach each other more gently. You know,
Yeah.
all of us, we need to be gentle with each other. And
Yeah.
I so appreciate that we're connected. And I know that a lot of people are going to be wanting to connect with you. So hopefully we'll see some of your social medias, because you're an incredible storyteller and just an incredible woman. So appreciate meeting you, and thank you for joining us today.
Thank you so much, Amy. Thank you.
All right, another one of my favorite people, Vic Armstrong, is here. Our old friend Vic Armstrong, and some strong talk to pull us through the end of the hour. Hey, Vic.
Hey, thank you. It is inspiring to see the level of interest and energy around community partnerships. It's important to remember, however, that when we talk about transforming crisis services and forming partnerships, there are some key factors that must be not only understood, but addressed. First of all, when we speak of transformation, of moving the field forward and building upon our foundational services, it is important to ask, move forward from where? Not all communities enter this conversation of transformation from the same place. Often, historically marginalized communities have not had basic issues addressed, including those issues that impair quality of life and fall disproportionately upon historically marginalized communities. Issues such as food insecurity, housing instability, transportation needs, racism, discrimination, and violence, polluted air and water, language, and literacy. Any effort that involves partnering with communities to improve mental health and addictions should at a minimum acknowledge the social drivers that disproportionately impact mental well-being in historically marginalized communities. Partnership, after all, is in the eye of the beholder. Second, as it pertains to crisis services, it is important to remember that in uncertain times, in times of crisis, when we feel broken, when we are afraid, when we feel alone and vulnerable, what we seek most is safety. We seek connection. We seek community. Community is built on relationships and connection. That relationship may be the deciding factor in whether a grandmother whose grandson is expressing suicidal thoughts without 988 versus calling a pastor. That connection may be the difference in a person of color choosing to call a helpline rather than suffer in silence. That feeling of community may be the deciding factor in whether I initiate contact with a mental health provider or whether I'm introduced to the mental health system in the back of a police car. Safety and connection require trusted relationships in which to thrive. Those relationships must be built on transparent, accurate, and frequent communication, including information about available access to resources. And access is about more than physical proximity to more of the same traditional resources. It's about having resources that are culturally relevant, resources that are relatable to my lived experience, resources that provide me with connection and safety, resources that reflect my community. A promise of transforming crisis services and forming partnerships is not only a promise of a better, more efficient system, it's a promise of safety, connection, and relationship to those who have been historically marginalized. It's a promise, not of building pathways for communities to find their way to us, but of building pathways for us to find our way to communities. And that is Strong Talk.
Vic, thank you so much. All right, there's going to be some slides coming up on what's coming up, but I just want to say a few words as we close down. Today, we heard over and over and over again about community. Vic talked about it. Rachel talked about it. Lizelle is grabbing from the community. We heard it from Jenna in Pennsylvania about how she's reaching out, having her liaisons in the community and the counties bring back information, and Brooks building it with the youth in Massachusetts. Let's keep going forward and reaching out to our communities, bringing them forward and seeing if we can serve them in the best way possible. I loved being with all of you today. Have a good day.